unilateral proptosis. دكتورة عندي فاتسة تقدر تردين؟
اي نعم دكتورة، ممكن سكرول ثاني. بعد دكتورة ايه بس سكرول اذا ممكن، يعني بس حركي الصورة. اي نعم. يس. بعد دكتورة رجعي لنا بس للمكان هنا. ساعات تمبورال ريجن دكتورة ممكن. يس.
شلون؟
تمبورال ريجن بعد ترجعي لنا ممكن سكرول. يس. عشان تيجي دكتورة عندنا تي 2 فلير. يس.
لا أفلام ما عندي تي 2
diffusion and ADC.
بس هذه هذا تي 2 دكتورة.
تمام 10 ايج. نعم. قلتي لي 40 years old.
40 years old female
تمام.
with the unilateral proptosis.
تمام. multi sectional multi sequence MRI of brain with contrast study. There is an obvious thickening, dural thickening involving the left temporal lobe with the obvious enhancement along the orbital apex and thickening, also soft tissue thickening and enhancement, including the orbital apex left-sided. On the same side, there is obvious bone expansion of the left sphenoid wing. I'm searching for any other obvious findings. I think no other finding regarding the imaged slice. دكتورة لو ممكن الكورونا تحرك لنا بس الكورونا. لا بالعكس، المؤشر يصير بالعكس. نعم. Yes, no obvious expansion of the orbital conal muscles. No obvious enhancement of the left optic nerve. With the obvious proptosis involving the left orbit. Yes. By the imaged slices, obvious meningeal thickening and meningeal enhancement with some orbital extension. دكتورة إذا ما عندها برايمري مثلا البيشنت هيستوري أو برايمري مثلا أو أني يعني بصمة هيستوري ما عندها بصمة
هي أصلا جتي فور كوزمتيك ريزن، يعني هي كانت عبالها جفنها نازل
تمام.
يعني وسوت عملية قص أجفان وظلت الاسيمتري بين العينين، فجت يعني ستينج فور
تمام. يعني استاذ احنا يعني انه يعني such imaging features and having no primary, the first possibility will be meningioma, meningioma and plaque, with such bone expansion. But if there is any history of primary, secondary, dural metastasis will be in the second differential. As it is a young, maybe 40 years old, young patient. Yes, we can say middle-aged patient, and such meningeal thickening and bone expansion, so meningioma and plaque will be the first differential. With the orbital extension. No obvious other findings.
جيد.
نعم.
شكرا دكتورة فاتن.
عفوا.
دكتورة لنشة.
نعم أستاذ.
صباح الخير.
صباح الخير.
Dr. Fatin said that is meningioma and a plaque.
No.
You agree, yeah? You agree?
Yes.
Okay.
The feature is going with in-plaque meningioma mostly.
You are right, okay. The management of this, first of all, the percentage of meningioma and a plaque. Do you know the percentage?
In-plaque meningioma, actually, it's not a very common type of meningioma.
Sure.
I've seen about, I think, about 2 to 10% maybe of meningioma. It's more common in the female, usually in the middle-aged female, just like a common type of meningioma.
Yeah. Okay. The management of meningioma in a plaque, is it similar to the classic meningioma?
No, because in-plaque meningioma is growing with the meninges, so the management is more difficult. It's not complete resection cannot be achievable in the most of the cases, and I think management is depend on the presentation. For example, in this case, on effect on the adjacent structures. But complete resection is usually not achievable. It could be just follow up in case when there's
any role
structure,
for,
or could be surgery with.
is any role for gamma knife or chemotherapy or meningioma? As you said, surgery is very difficult because it is separate within the meninges, and surgery is difficult.
Actually, I don't.
Is there any role for gamma knife? Or?
I don't know. I don't have any information about that.
Okay. أكو أحد عنده معلومة على المانجمنت of meningioma and plaque؟ أوكي لنشي، شكرا جزيلا. شكرا.
عفوا أستاذ.
دكتورة زهراء.
نعم.
أوكي يلا احكي لنا على الكيس بنتي وإذا مسوي توك حتى نروح عليه. تفضل. لا احكي أول مرة على الكيس قبل التوك. زهراء.
إيه لحظة دكتور.
عليك كيفك.
بس شلون أطلع؟ دكتور هي 40 years old female with proptosis and no visual disturbance. So the MRI showed an extra-axial dural-based, avidly enhancing, homogeneous, avidly enhancing, insinuating lesion. It is located at the anterior part of the middle cranial fossa, and with extension to the ipsilateral cavernous sinus. It's more obvious on the coronal image, and with intraorbital but extraconal extension, and cause medial displacement of the lateral rectus muscle. So with associated with hyperostosis and expansion of the left greater wing of sphenoid. So, the case typical for any plaque meningioma.
كيف الحالة التوكبيت؟
نعم. Meningiomas are the most common intracranial neoplasm and the most common extraaxial mass, representing up to 30% of all meningiomas are histologically benign WHO grade 1 tumors and are of two basic morphologies, either expansile mass with wide dural attachment or any plaque growth in sheet-like pattern along the dura. Pathologically, they arise from arachnoid cap cells. About any plaque meningioma, it refers to a specific macroscopic appearance of meningiomas characterized by diffuse and extensive dural involvement, usually with extracranial extension into calvarium, orbit, and soft tissues. These tumors are thought to have a polar-like or sheet-like growth along the dura mater. Different from the usual globular meningioma, this is a gross finding of a bone resected from any plaque meningioma patient. The outer table of the bone is smooth, while the inner table is eroded and show irregularity and fragmentation of the dura. About the epidemiology, any plaque meningioma account for 2 to 9% of all meningiomas. It is 3 to 6 times more common in females, and the mean age of presentation is 40 to 50 years. Clinically, the most common presenting symptom is proptosis, headache, ptosis, diplopia, and unilateral visual impairment. Just a note about the proptosis can be assessed radiologically by interzygomatic line. One of the measurement is measuring a line from the interiormost of the globe to this line, which should not exceed 23 millimeter. The location of any plaque meningioma is primarily located in a spheno-orbital region, where the less common locations are cerebral convexity, temporal bone, and foramen magnum. So this is the typical site of any plaque meningioma and how it extends to the orbit mostly through superior orbital fissure. Radiographic features. Contrast-enhanced MRI is the preferred imaging modality. The extradural soft tissue component of tumor, which appears iso-intense on T1 and iso to hyper on T2, show intense homogeneous enhancement on the post-contrast scan, with the dural and osseous invasion are commonly encountered. Calvarial thickening is a common finding seen at imaging, as these lesions are well known to invade and expand the adjacent bone. Post-contrast fat-suppressed T1-weighted images are especially useful to evaluate the orbital or soft tissue extension of the lesion, while the osseous changes, CT scan is superior for viewing them. This is a case of any plaque meningioma. The greater wing of sphenoid on the left side show a loss, expansion and loss of its normal fatty signal, and show post-contrast and with T1 post-contrast fat suppressed enhancement and the typical soft tissue dural-based component from the middle cranial fossa to the orbit. This is another case with the typical features. The CT scan show the osseous changes more with the lesser and greater sphenoid wing involvement and anterior clinoid process involvement, while the MRI show the soft tissue component and the typical middle cranial fossa to orbital invasion. Also, this is a temporal fossa invasion. Another example with the same typical features of hyperostosis on CT and the dural enhancement and loss of normal fat of the bone with its expansion. About the differential diagnosis, we have osseous part and we have dural part. First of the osseous metastasis is of the differential is the osseous metastasis, mostly the sclerotic. This is a case of prostatic CA metastasis, spine and skull metastasis. Here we have two lesions, one in the occiput, and the other one is centered in the greater wing of sphenoid. On the left side, show a speculated sclerotic lesion. This is the MRI of the same case. Show the greater wing of sphenoid. It's the mass centered in it, and it shows centrally it is sclerotic, hypointense with minimal enhancement peripherally. There is no homogeneously enhancing dural based mass seen in plaque meningeoma. The other differential is intraosseous meningeoma, which is a rare subtype of meningeoma that account for less than 1% of all osseous tumors. Radiographic features, the majority, 65%, are osteoblastic, while the rest is osteolytic. CT shows the sclerosis and expansion, while MRI show the mass to be iso on both T1 and T2 with the transosseous enhancement. This is a case of intraosseous meningioma with hyperostosis and proptosis. This is the mass in the greater wing of sphenoid. Show the loss of signal, expansion. The CT show the hyperostosis, and minimally there is enhancement without dural-based mass. Well, there's a controversy about considering intraosseous meningioma and plaque as the same entity. But whenever there is a soft tissue component and dural-based mass, it is more an plaque meningioma. The other differential is craniofacial fibrous dysplasia and Paget disease, but both more diffuse and have distinct features. Fibrous dysplasia show the ground glass opacity, while Paget more diffuse and heterogeneous and not this homogeneous sclerosis seen in meningioma. About the dural masses, we have the dural metastasis, which is also known as pachymeningeal metastasis. It is a relatively common cause of dural masses, although it is less common than brain metastasis and meningioma. By MRI, more typically multiple can be focal. By T1, it is iso to hypo, T2 iso or hyper, and show vivid enhancement. The MR spectroscopy may be of benefit, as the dural metastases show a prominent lipid peak and occasional lactate peak, while meningioma show no lipid or lactate peak. This is a case of a prostate CA patient with dural enhanced metastasis, also at the anterior part of the middle cranial fossa, and there is another dural enhancement in the parietal lobe. The other differential is Tolosa-Hunt syndrome. It is an idiopathic inflammatory condition that involves the cavernous sinus and orbital apex, and is essentially a clinical diagnosis of exclusion. By imaging, show inflammatory changes in the region of cavernous sinus on the affected side with or without enhancement, and its extension to superior orbital fissure and orbital apex make the differential with plaque meningioma. It shows enhancement during active phase and resolution after treatment. This is a case of Tolosa-Hunt syndrome. Show marked thickening and enhancement of the right cavernous dura with extension into the orbital apex and anterior temporal lobe. The patient had significant improvement following steroid treatment. About the treatment and the prognosis, it is surgically treated, and due to the extensive and invasive presentation of these tumors, sometimes closer to vital structures, complete resection is usually not achievable, and partial removal can lead to a higher chance of recurrence. Also, there is a role in the radiation therapy. These are the images of our case and the references. Thank you.
شكرا جزيلا.